This is lecture number 6 in nu210 Nursing Concepts. Last week we looked at professional behavior in nursing, and we ended up with talking about delegation. It's a very important point. So we want to this week start out by repeating some of that content and specifically focusing in on delegation itself. Of course, we give Dr. David Sharp credit for composing these lectures. On your PowerPoint slide, you see a picture of Florence Nightingale and makes a statement about delegation. Quote, "To look at all these things yourself does not mean to do them yourself," unquote, from Florence Nightingale's quoted in the Catalano textbook. Now, what is delegation? It's when an authorized person acts in the place of the RN and carries out the tasks or the hands-on things that need to be done for the client that fall within the RN scope of practice, but the thing is that person who's delegated to, they've got to be qualified to perform the task. So when we look at the comparison with ancillary personnel carrying out tasks that fall under their own level of practice compared to falling under the nursing scope, that's not really delegation. They're just completing their duties, and you're completing your own duties. But whenever you have something that you're supposed to be doing and you delegate it to somebody else, that person has to be competent and able to perform that in the same skill level that you would. Now, why do we look at this? Because it's important, because NCLEX covers this quite a bit. There can be several questions in your NCLEX licensure test that address delegation, and they want to know that you do understand what it means to delegate and who you can delegate to, and that there is a process involved in delegating properly. Well, why? Because even a newly qualified RN, even as that, you will have to delegate to somebody. It's one of those things that we consider a basic, fundamental, foundational skill of nursing, is knowing who you can delegate to and which clients can be delegated to someone else and what tasks can be delegated to another nurse. Now, the thing is that you are a part of a healthcare team and you're a key player in that team. You have independent ability to practice certain things as other RNs do, but you have accountability. Everyone's accountable for what they do themselves. You need to be able to lead and delegate. As a bachelor prepared nurse, this is one thing that you have extra in your toolbox, is you learn leadership skills. They learn this on a very basic level in an associate degree program, but we have even an extra senior level course called Leadership and Management, in which you will learn leadership, and of course delegation is a key part of that. Now, if you do delegate a task, remember the RN must always supervise to ensure safety and standards are met. You can't just ask somebody to do something and then not check up on it later. You need to make sure that the outcome was acceptable, professionally done, and done in a safe way. And RNs are considered to be professionals, therefore authorized to delegate independent nursing functions to other personnel. That's part of being in this profession, is that you do have that authority to delegate to other people. However, some functions cannot be delegated. For example, you as an RN cannot delegate your assessment of your patient. You cannot delegate composing a care plan to someone else for your patient. You must make the diagnosis for your client. And then, of course, when you're teaching and discharging the patient, then you must do that. Now, many times there's what's called a free charge nurse who does the discharging of all the patients on the floor, and that's wonderful because that frees you up to be doing other things. So they will do the discharge teaching and discharge planning and discharging patients, and that's okay because they're the charge nurse and they're free to do that. They actually have authority above you. So they're just helping you out so that you can be free from certain stresses, especially if you have a very, very busy team of patients for that day and they're very demanding and have several acute patients. Now remember, what she's doing, or he or she is doing when they're discharging the patient, is that patient is stable enough to be discharged home. So it's not like they're taking on something that they can handle. This is something that they do all the time. When they're discharging or admitting patients. Even some free charge nurses will admit your patients for you when you get them. But they won't do the assessment and they won't do the care plans and the diagnoses. You'll have to do that yourself. And it's part of the nursing process. We look at how does this relate to delegation? Well, the task can come under the assessment and the nursing diagnosis and the care plan. Now, when you're looking at what's to be delegated, then that's under implementation of care. So that's actually doing hands-on things, doing things that are taking care of the patient, making sure that their needs are met. Now, some of those things can be delegated, and you have to determine if that patient is stable enough for you to be able to delegate some of those tasks to somebody else. And then, of course, the RN makes sure that the evaluation is complete, that what needed to be done got done safely and completely and is in an acceptable way in a professional manner. So let's just summarize this delegation and how the nursing process uses it. When a patient comes into your care or when they are leaving your care, you have to look after them. You need to do their assessment. You need to do the evaluation. Well, on admission, you've got that assessment and care planning. You write that care plan. You do their full head-to-toe assessment, and that takes in all of the holistic areas of nursing. You're dealing with not only the physical, but the mental, spiritual, and you make a care plan that is specific to that client. Now, when they leave, you need to teach them and do the discharge planning, do the discharge teaching, and discharge them properly. And you need to close your care plan and say that these things are ongoing or they've been accomplished and they met the goals, etc. But see, in between that process of admitting and discharging, you've got to look after the unstable clients and patients with acute conditions. You cannot delegate unstable clients or acute clients to someone else. You've got to take care of that yourself if that team was assigned to you. We call that dumping, and you cannot dump on another nurse. You've got to watch after them. You delegate care for the stable clients and the chronic clients to other folks. That means with you taking responsibility for the patients that have the most needs under your care. Now, if you do delegate a task, you as the registered nurse remain accountable for the outcome, and this is defined by the American Nurses Association. There's no liability attached. The person delegated to practices under their own license or within their own level of education if unlicensed. People are responsible for their own actions if delegated a task. That means that what they were trained to do, they can do that with any client. Doesn't even have to be on their team. It can be someone that was in another team that's delegated to them, but you can't expect them to work outside of their scope of practice or to do something that they're not supposed to legally do or are unable to do. You remain accountable for the delegation process. It's got to be appropriate to what that person is educated to do and what they're able to perform in their skill sets. So, can't be outside the scope of practice, their educational level, or their ability to fulfill skills for that person. Remember before we talked about what if a client dies? Well, the RN was accountable for the delegation. Must be appropriate for education and skill level. And if the assistant personnel has accepted responsibility for the task, they have taken responsibility for therefore they are responsible for the death. If the RN delegates inappropriately now and that person dies, then they give that to a person who is not qualified. The RN and the assistant personnel could both be held liable. The assistant personnel has accepted responsibility when they should not have. So they have the right to say, no, I'm not supposed to do that. I'm not able to do that when you ask them to do something. If they're in a different scope of practice or a skill level, they've got to let you know what they can and can't do. Now, as you work with them longer, you'll already know that. You'll learn that as you're going, and you'll remember. Now, here's some guidelines for delegation. First of all, you've got to assess the client. That's your responsibility as a registered nurse. You've got to determine whether they're stable or whether they're chronic. Okay. Then, if they're stable or are chronic, then they can be delegated. Okay. If there's uncomplicated routine tasks that are performed without variation from policy or procedure, then there's no nursing judgment required. These are called repetitive tasks where RNs can be used more effectively elsewhere. So those things can be delegated. You need to know who's available. You need to know what they have as far as education and competency levels, And you need to match up that with what care is needed to be given. You need you need to know who is comfortable with doing those things. Know the staff, know the people you work with. You need to know your job description and their job descriptions. You actually have to learn what UAPs can and can't do, and don't ask them to do something they're not supposed to do, especially if it's an institutional policy. There are some things in the guidelines written by the nursing board, but there may be more specific things in the policy and procedure written by the individual institutions. And sometimes you have to educate the staff member. You might be responsible for educating them about a delegated task. And there's got to be some documentation training. You've got to demonstrate to them, how do you write this out? How do you make sure this is documented correctly? What's expected of them to complete that task? And could there be any complications that they need to watch for? Something that is specific to that task that can happen at times, which is not a good thing, but they need to be prepared just in case it does. So you want to educate them about that. And of course, you've got to see them do that once and answer the questions they might have if you're going to continue to delegate to them in the future. Now, when we're dealing with what we call aides or techs or UAPs, unlicensed assisted personnel, there's got to be clear and predictable outcomes. It can't be something that is so complex that you can't predict what might happen during the task. Predictable and uncomplicated outcomes are expected after they perform the task. They should not require excessive supervision. You need to be able to ask them to do that and not have to stand over their shoulder and watch them do that. Complex decision making or detailed assessment of the client, such as feeding of a stroke client with hemiplegia, etc., that can be quite complicated unless they, like I said before, are working in a nursing home on a regular basis, and they're especially trained for that. Now, if any of these things are required of them, then maybe you should reassign it to somebody else, or maybe you should not give it to them and take care of it yourself. Give them more simple tasks, okay? Now, you can practice delegation questions with one another as a group, but you don't need to be afraid of those questions. So you can take a few minutes maybe to think of some delegation questions and maybe share them in our discussion board or the chat room. This is the end of part 1 of this, and we'll take a quick break and pause this and write out those delegation questions that you think of, and then we will resume the audio with part 2 of this week's lecture. So we're back with part 2, and part 2 of this week's lecture deals with communication in nursing, which is so important. And if you remember, in our 4th lecture, we introduced you to SBAR. Do you remember what that means? Can you write out what that acronym actually spells out? Take a brief moment to take a pencil and paper, a pen and paper, and what does the S stand for? What does the B stand for? The A and the R? Well, the S stands for situation. So we want to specifically look at this and reiterate this because this is very important. What's going on with the patient? Identify yourself and the client and describe the problem. Second, the B stands for background. We want to see the summary of their past medical history, their diagnoses. What is their current mental status? Are they awake and alert and oriented, or are they confused? Are there vital signs within normal limits? What are their complaints? What are they saying is going on with themselves? Is there pain involved? And rate that on a level from 1 to 10. What's their oxygen saturation, which should be above 90%, hopefully between 95 and 99 on room air. And then do a physical assessment, and that is reported as your background. Third, the A stands for assessment, and we're analyzing the situation, not the physical assessment. We're analyzing the situation that's going on. This is the situation that you're calling the physician about. And isolate the problems if their vital signs are outside normal parameters. What do you see when you look at this client? How do they clinically present themselves to you? You need to rank the severity that you judge the client to be in at that point. Are they hyper acute? Are they very acute? Are they, use the term sometimes, they're crashing. We're suspecting that they're really heading for a bad situation. You need to identify the specific client needs to resolve the situation. And then finally, the R stands for recommendation. You as a nurse, what are you recommending? What are you saying you need to that physician? What are the actions you think need to be taken to resolve the situation? So how do we get rid of this problem? How urgent is the problem? When does it need to be done? Do we need it stat, or can it wait for a little while? And you just make a suggestion. What's your recommendation? And you say, well, here's what we really want to see happen with this client to get them out of this situation, to turn around. Maybe it's just simply a blood pressure problem, and you've got to bring a blood pressure down. So your goal is to get that blood pressure down from a high level that's unacceptable. It's not within normal limits. And you would say, well, I just really need to bring their blood pressure down, and maybe they're having a severe headache from that, or they're having some other symptoms, neurological symptoms. And you need to make a recommendation as to what you think needs to be done to get that situation resolved. You have to learn how to communicate effectively with the clients, with the clients' families, with everyone in the community, with medical personnel, with nursing administrators, with the colleges that come and bring their students to your floors where you're working, with junior level nursing staff, and of course with student nurses and the instructors. Why don't we take a few minutes to list 4 factors or situations that produce high levels of stress for student nurses? Because stress influences the ability to communicate effectively. And then list 4 factors or situations that produce high levels of stress for nurses in hospitals. And I know this is kind of reaching for you, may not have been exposed to nursing and hospitals, but just take a few minutes to pause the audio and list these 4 factors for high stress levels in student nurses and then in nurses for hospitals. So pause the audio now and take a few brief moments to write those down. Now that we're back, know that you will deal with clients who are under stress. You will work with colleagues who are difficult to deal with, and that's going to cause stress for you and the colleague. But you've got to cope with difficult behavior in clients. You may deal with manipulative behavior, and that could be from the client or anyone else that you work with. You may face sabotage of your work. You're going to have to deal with diversity. You're going to have to deal with conflict. And you have to be aware of your own personal communication patterns. Where are the weaknesses? Where are the strengths? And all of these things can cause stress for you as a nurse and as a student nurse. So we look at page 283 in our Catalano text, and we see box 14.1. And you see there the barriers to and benefits of clear communication. Pause the audio and take a few minutes to read that over. Now we're back, and we want to talk about assertiveness. Now you as a individual, when you think of assertiveness, do you think of that as a good or a bad thing? Well, it's actually a good thing, because as a nurse you need to be assertive in your communication. Now you have, quote, the choice to voice an opinion, sometimes forcefully, as well as not to say anything at all, unquote. And that's in your Catalano text in page 283. Assertiveness is a learned skill, and it takes practice. This is something that you may not have been raised with, so you have to learn it during this time of training in your nursing program. As you go into clinical practicums, you will need to be assertive. And if you're not assertive, then you may be taken advantage of. You may be what we call being walked upon, being walked on. And folks that aren't assertive in a professional mannerism and never stand up for what they know to be right, they can get burnt out quickly in nursing. They can become totally burnt out. And we don't want that to happen. We want your nursing career to be a long and rewarding career. Now, as you enter your junior year of this BSN program, you will take an individual course about therapeutic communication, and it will teach you about assertiveness. Now, how do we resolve communication problems? We've got to put the focus on a win-win. We don't want someone to be a loser in this. We want everyone to be a winner. We are a healthcare team. Everyone is equal. We deserve mutual respect, and we deserve good communication between one another. You need to be willing to negotiate and compromise. Just because you negotiate and compromise and give in doesn't mean you lose. Don't look at it that way. Remember, it's win-win. Be direct and honest. Focus on the issues, the specific issues. Don't get off on rabbit trails and peripheral things that don't have anything to do with what you're trying to deal with. Don't personally attack the person. Don't make judgments of condemnation upon them. Don't look at them as bad people or bad nurses. Know that they are your peers and you are working on solving a problem as a team. Don't become the third person. Encourage peers to go direct. So we don't want to be sharing our problems with nurse A with nurse C or hearing about it that way. If you have a problem with nurse A, go to nurse A and talk to them about it in a very professional, assertive way. And don't be part of the gossip mill, the rumor mill. Don't be that type of person who talks bad about other people and who always communicates a negative situation to other nurses, and it just brings everybody down. And problems don't get solved that way. Don't be cliquish. Be open, professional, and friendly with all of your peers and with everyone that you work with, all of the ancillary staff, all of the other folks that work in the institution. How about let's look at personal behavior when communicating. You need to listen attentively to the person that's communicating to you. They need to feel that you hear and understand what they're saying. Give them a nod. Give them a look that's like, yes, I know where you're coming from. Now, if you're going to confront somebody, do it in person. Never in front of anyone else. Take them to a room, the conference room, the kitchen, the break room, and make sure no one's around. Shut the door and talk to them about it. Confront the individual first. Don't just go and report them for something that they did. Don't just go tell the supervisor before you've talked to this person. That's not the proper chain of command. That's not proper protocol. Talk to that person. And don't confront them or be assertive with them when you're angry. Start with an I message. I feel like you did this. I feel like, well, I noticed that, okay? Observe, express your observations, feelings, and opinions, and do it honestly. Do it quietly. Don't do it loudly. Don't do it rudely. Do it with mutual respect for that other person. And allow the other person to talk without interrupting them. After you are done stating your case and your thesis, then stop and let them answer you, and don't interrupt them when they're talking to you. Now, we need to set goals and future plans of action. We need to keep it private and confidential. And then let it go. Don't take it home, and don't hang on to it for weeks at a time. Don't let it become something that's hurtful or a sore open wound. Now, what does assertive communication mean? Assertive communication. We combine the assertive behavior with effective communication now. One of the things is we maintain eye contact. Now, you have to remember, there are certain cultures that don't like eye contact, so know who those cultures are and avoid that in that situation. But most of the time in this country, we maintain eye contact to show that we are assertive. Convey sympathy. Stating your feelings does not mean sympathy or agreement. So convey sympathy. Don't just state your feelings, okay? And know that if you're sympathetic, it doesn't mean that you agree with everything, but it just means that you understand and you have some sympathy for that. Keep your body position erect, your shoulders and back straight. Don't slouch and look overly humble. Don't get in their face. Don't get close to them. Don't interject yourself in that personal bubble to make them feel threatened. Speak clearly and audibly. Be direct and descriptive. I would add to that, keep it simple. Keep it simple and easy to understand. So clear, audible, simple, direct, descriptive, easy to understand. Use their language. Use the language that will communicate effectively with them, the way that they speak. Be comfortable with silence. Don't think that if nothing is said that nothing's happening, because something could be, they could be thinking of something contemplatively and deeply in their mind, and they want to make sure that they don't answer in a way that would be offensive, so they're checking their own selves. So be comfortable with that silence. Use gestures and facial expressions for emphasis. Your eyes, your face. Don't look offended, and they won't think that you're offended. If you look at them in an understanding way, they know that you understand. Use appropriate location. So don't do it in the hall. Don't do it in the cafeteria. Go to the break room or conference room. Shut the door. Use appropriate timing. You don't want to assertively communicate or confront another nurse when they're really, really busy, stressed out, and whatever. You need to wait till they have some time to share with you. Focus on behaviors and issues. Don't personally attack that person. You may not like them, but don't let them think that you think they're a bad person. Respect them, and they will respect you. Now, Catalano brings up what's called the 7 principles of communication, and here we have them listed. Number 1, information giving is not communication. It's easy to share information, but that doesn't mean you're communicating. Communication is a give and take occurrence. It's an understanding thing. It's the sender giving the proper message and the receiver receiving the same message. The sender is responsible for clarity. The one who is saying, I need to talk to you about this, they need to be able to explain that to you in a way that the receiver can understand. Use simple and exact language. Number 4, feedback should be encouraged. Number 5, the sender must have credibility. Number 6, acknowledgement of others is essential. Number 7, direct channels of communication are best. This concludes our lecture for today.